Hello, everyone. Welcome to today's lecture. Thank you for the introduction. We hope this will be an informative, patient-centered talk on the symptoms of endometriosis, available diagnostic tools, and real-life management. Again, my name is Anya Frost. I'm an assistant professor in the Division of Minimally Invasive Gynecologic Surgery here at Johns Hopkins.
And I'm Harold Wu, also a minimally invasive gynecologic surgeon here.
So neither of us have any relevant disclosures. Our only disclaimer, just for any of our more sensitive viewers, is this webinar does contain real intraoperative surgical images. So an outline, looking through what we're going to be doing today. Again, this is a really big, comprehensive topic, so we're going to try to give you a surface level overview of a lot of different topics. We're going to start with basic definitions. What is endometriosis? What do we know about it thus far? How and why does it occur? We'll go through common symptoms of endometriosis, various diagnostic and evaluation tools. We'll talk through available treatment options, of which there are many. We'll try to dive into a little bit of considerations in the context of fertility, which could be a whole lecture in its own. And then briefly at the end, we'll touch on kind of what's on the horizon. What are people looking into? What is new and evolving data and research in the field? So the definition of endometriosis. Endometriosis is a chronic hormone-dependent inflammatory disorder typically seen in reproductive age patients. The classic definition is the presence of endometrial tissue, which is the cells from the inside lining of the uterus seen outside of the uterus, typically within the pelvis. Now, symptoms can be very variable. We can see patients presenting with no symptoms at all, and we find it as an incidental diagnosis, either on imaging or at the time of other surgeries. Most commonly, we see patients presenting with painful cycles, with pelvic pain in general, and some patients we see presenting in the context of difficulties with fertility. So who is affected? We briefly touched on this before, but typically premenopausal women, since it is a hormonally dependent disorder. The prevalence has been seen to be, as high as 10 to 15%. And we're trying to improve that diagnosis in patients that are affected. We see the peak between the age of about 25 and 35, which obviously is a critical age range since we see a big childbearing population within this age range. Now, there are differences in prevalences by subpopulation. We can see, like I mentioned before, in as high as almost 10% of asymptomatic patients, which makes it difficult to sometimes diagnose and treat. And in our infertility and pelvic pain population, it can be seen in as high as 50% of patients, so a big difference. Some risk factors we know about. This list is not comprehensive. There is a lot that we still don't know about the disease process. But we can see a higher prevalence of the disease in patients that have never been pregnant or have fewer pregnancies, having a young age when cycles begin, more frequent cycles, a longer duration of flow, any congenital issues that cause an obstruction of menstrual outflow. So that's a smaller population. And then we do see that there can be a genetic component, not always, but in a first degree family member, we do see sometimes up to an 8 times increased risk in other members.
So, how and why does endometriosis occur? Well, the definitive cause is unknown, but several theories have been proposed. By far, the most popular theory that makes the most sense really is retrograde menstruation for the most part. So that's essentially where the period blood, including the endometriosis cells, can then travel backwards to the tubes instead of just going out through the vagina like they usually do. And then as they travel into the pelvis, they can implant on various parts of the pelvis, other organs, and then cause endometriosis. However, importantly, greater than 90% of patients do have some level of retrograde menstruation. It's not technically abnormal, but not all patients develop endometriosis. So there are definitely other factors at play and potentially other theories. For example, there have been case reports of endometriosis going to rare, unusual locations like the groin or pelvic lymph nodes. There's cases of endometriosis in women or patients, young girls who haven't really had their periods yet, and even endometrial tissue sometimes in men who have had hormonal therapy, female like estrogen-based hormonal therapy for prostate cancer. So lymphatic and vascular spread has been described and processed, as well as coelomic metaplasia, which is basically just a fancy medical term for, when the the cells in the lining of the pelvis or other organs can then change into endometriosis cells, or even the stem cell theory, right? So stem cells in the bone marrow or other tissues can themselves change into endometriosis cells as well. There are, of course, additional contributing factors. For example, there are certain endometriosis lesions that sometimes have the ability to make their own estrogen that feeds and stimulates themselves, or even that have resistance to progesterone, another female hormone that usually antagonizes the effects of growth on endometriosis. Obviously, inflammation is a big factor, right? Because you shouldn't have blood or cells that create blood in your pelvis. The immune system usually is responsible for clearing abnormal cells. So some patients may have decreased or changes in their immunity where they can't clear those endometriosis cells in the pelvis or elsewhere. And like Dr. Frost already mentioned, genetics is a big deal as well. It's likely a very complex pattern of inheritance, so it's not quite simple, a little bit difficult to study in a multifactorial nature, but there's definitely increased incidence in first degree relatives. But all of this really speaks to the incredible complexity of the disease, and it probably all works in some way in concert to create the overall clinical disease as a whole.
So, looking at conditions that we can see in conjunction in patients with endometriosis. Now, there has been more data that has emerged recently that links a lot of additional conditions to that of endometriosis. Now, which causes what, or are they more related from an autoimmune nature of the disease process? We don't know, but we do know that having endometriosis can put individuals at greater risk of other conditions. Now, this list on the left again, is not completely comprehensive, but is a list of conditions that we do see more frequently in patients affected by endometriosis. Starting at the top, autoimmune conditions. So those are like lupus, Crohn's, your thyroid diseases. It's not uncommon that we see patients with concurrent bowel symptoms, which can be hard to parse out. Is it a separate condition? Is it related? Because all of these organs sit closely, intimately related within the pelvis. So irritable bowel function, and functional bowel disorders. We often see patients with pelvic floor dysfunction in concurrence with endometriosis, which is a muscular condition of the pelvis that can create a lot of pelvic pain. We can see nerve-related conditions like neuralgia. We can see evidence of painful bladder syndrome, also known as interstitial cystitis previously, and then multiple other more systemic full body muscular and connective tissue disorders such as fibromyalgia and Ehlers-Danlos. On the right is a list of, again, not comprehensive, but a list of symptoms that can actually mimic the disease process. So you'll see later in our evaluation slide is a lot of evaluation at the beginning is ruling out other conditions that can mimic endometriosis. So things like pelvic infections, urinary tract infections, infections or diseases of the bowel. Fibroids based on size sometimes can cause pain symptoms and a variety of different ovarian masses. So again, speaking to a lot of the complexity of this disease process, both in understanding its nature and its overall diagnosis and treatment. So where is it found? Since the main theory behind the disease process is what Dr. Wu mentioned, the retrograde menstruation, the most common locations we see it in the dependent areas of the pelvis. You really just think of that like gravity locations, right? Here is a view of the pelvis, kind of the uterus highlighted here. These red dots are areas we can find endometriosis all over. The most common we see is in the areas behind the pelvis and along the pelvic side walls, or the filmy tissue that lines the pelvis called the peritoneum. Less common, but we do see lesions that can be on the bowel or the bladder that can sometimes infiltrate more deeply into those organ spaces. We can see endometriosis located within surgical scars. So that includes prior laparoscopic scars, prior cesarean section scars. We can see lesions located within the belly button, which speaks to the other abnormal natures of spread of the disease. And rarely, but we can see lesions located within the lungs called thoracic endometriosis. Now, beginning some of those more sensitive pictures. Now, what can it look like? Well, as you can tell right away from these pictures, highly variable. And this does not even encompass all the potential visual outcomes. So in the upper left, superficial peritoneal implants. This is our most common. What we see is lesions that lay on the peritoneum, which is tissue that lines our entire abdominal and pelvic cavity. These are your classic lesions that we learn about in medical school that are called powder burn lesions, but this is certainly not the whole breadth of how endometriosis can look. So it's really important when you go to surgery that whomever is taking care of you has a high clinical suspicion and knows the variety of presentations. Now, these other two pictures are a little bit more dramatic. On the right, we see ovarian cysts or endometriomas, which are cysts filled with old blood and indicative of slightly more advanced stage disease. We'll talk about that topic a bit later. And then we can also see deeply infiltrating lesions. So here you're seeing evidence of just significant inflammation, organs connected to one another that shouldn't be. Sometimes it's just scarring. Sometimes the lesions infiltrate more deeply into those associated organ spaces. You're muted, Dr. Wu.
Oh, these are the common symptoms that patients often present with that we talk about with patients a lot for those with concerns or diagnoses of endometriosis. So in a study of 1,000 women with endometriosis, roughly a large majority, 80% about will have some type of pain, which we'll delve into a little bit. And then infertility is a major concern as well. Of course, an ovarian mass that Dr. Frost just mentioned. But importantly, a good number of patients also have no symptoms. They can have endometriosis found at this time of an incidental surgery for fibroids or something unrelated, for example. In terms of the specific kinds of pain, most commonly we are talking about cyclic pelvic pain, painful cycles, dysmenorrhea, right? These are all synonyms, medical terminology for some of them, but painful intercourse can be a very important part of the presentation. And then, of course, pelvic pain outside of periods as well. And the mechanisms for this is one that's quite obvious is the pro-inflammatory environment where inflammatory mediators are released. There's more inflammation, more pain, mass effect, right? So like bulk symptoms from ovarian masses, for example, anatomic distortion. Usually scar tissue doesn't cause pain per se because nerve tissue does not grow in scar tissue. However, if organs are significantly tethered or anatomy is altered, like in the pictures you just saw, that can certainly lead to discomfort and pain. And then, of course, site and organ specific disease. So, for example, if there is bladder or ureter involvement, there could be concerns for urinary symptoms, bleeding in the urine, like blood in the urine, especially during the cycles. For bowel lesions, you can have constipation, diarrhea, changes in sensation with bowel emptying, bowel cramping. And then, in some more significant scenarios, you can also have blood through the stool, especially during the cycles. For abdominal wall lesions that we've mentioned, you can have some swelling. Patients may have some swelling around the time of their cycles or even bleeding through the areas where it comes out through the skin or near an incision site. And of course, thoracic lung endometriosis, right? So in there, you can have chest pain, usually cyclical, kind of lines up with your menses or periods, and then even cough up blood in most severe cases. However, it is important to remember, that because of the inflammatory milieu or the environment in the pelvis, generally during patient cycles, a lot of other symptoms that may be involved with bowel or bladder function, like painful bladder syndrome, IBS, for example, can worsen or flare around the time of periods. So having certain of those symptoms doesn't necessarily mean that the endometriosis is deeply infiltrated into the organs. Overall, I would say that's quite rare, much less than 1% based on our studies and literature. But it's so important to be aware and to discuss those concerns with, endometriosis experts. Recent studies involving endometriosis and chronic pelvic pain have not surprisingly implicated significant involvement in the nervous system and a sensation of pain at all levels. So, clearly the endometriosis can infiltrate into nerve tissue and cause pain, but we've also shown that patients can sometimes have upregulation of pain receptors when they're having chronic painful periods or chronic pain issues from the chronic inflammatory environment. There can also be increased pain perception as pain signals abnormally become modified or amplified during processing up the spinal cord to the brain and back down. And so ultimately, these mechanisms can lead patients to be more sensitive to painful stimuli or even have pain from stimuli that are previously not actually painful. And as far as fertility concerns are regarding fertility concerns, there are really two primary mechanisms we usually think about, right? So you have the chronic inflammatory state. You can see a very clear pattern of inflammation everywhere. So that can obviously impair function of endometrium, right? That's the lining cells of the uterus, the cavity of the womb, but also fallopian tubes that, transport eggs and sperm, or even impaired egg quality and quantity. And as you can see from the picture there, which is also a little drastic, but definitely not something that we see not uncommonly from our referrals, really advanced stage endometriosis with lots of anatomic distortion and scar tissue. So that can clearly impair actual egg release, pick up the structural integrity of things, the physical nature of movement of sperm and egg, and blocking fallopian tubes, for example.
So now getting a little bit into evaluation. So this is a difficult topic. The biggest thing that I stress here is the importance of annual GYN care, and not because the onus is all on you as a patient to make sure you get recognized and get diagnosed, but the importance of just being able to voice your symptoms. There's also a big push in the community for physicians to be better educated, not just GYN, of course, but physicians outside of our specialty to keep this on their differential so that patients can be referred to the correct specialists as needed. Now, a physical and pelvic exam, there's an asterisk here because most of the time, again, on these exams, a lot of the findings will be normal, which does not exclude the disease process. And a lot of this, we're ruling out a lot of those other conditions I had listed on that previous slide, because it's very common that there is multiple reasons that patients have pelvic pain. It's often not just one, quick fix or one diagnosis. Similar in laboratory testing, there have not been any proven lab studies to diagnose endometriosis. We'll touch on that a little bit later in the Horizon slides. But this is also primarily to rule out other causes of pelvic pain, acute infections, things like that. Imaging, so bread and butter, most providers are going to start with a pelvic ultrasound to rule out any major structural causes. Again, can be completely normal and can still have evidence of endometriosis. So it again does not exclude the disease process. MRI is an imaging tool that we use a lot, both for fibroid mapping, further evaluation for endometriosis, surgical planning. So it definitely is a bit more sensitive in the diagnosis, but absolutely can still be normal in a patient that is affected by endometriosis. In terms of diagnosis, so I had showed some visual appearances of superficial endometriosis on the other slide, but as you can see here, this is 8 different views that all are consistent with endometriosis, but all look pretty different. So for that reason, the definitive diagnosis is with tissue biopsy, meaning excising or cutting out tissue and confirming it by a pathologist under the microscope. Visual confirmation is of limited value, so you shouldn't just look inside and say, oh, yes, you have endometriosis. And get out. It's really important to get some type of tissue diagnosis to confirm the diagnosis of endometriosis. In terms of diagnosis, so there are multiple classification systems that exist. So I have patients asking me that. That's not uncommonly. I'm a stage 2. What does that mean? Does that mean I won't be able to get pregnant? Does that mean my symptoms will come back? Does that mean I'll need more surgery? Unfortunately, these stages, stage 1 through 4, have not been shown to correlate directly with both severity of symptoms and outcomes, which it makes the disease process even more difficult to treat. The thing that they are best for is for a standard approach for reporting findings, right? So the way that I find them of most value is me reporting findings to Dr. Wu, or if I go back to do a repeat surgery on a patient, knowing what I saw previously. There is one classification system that's put out by the Society of Reproductive Medicine that does have some fertility outcome correlation, but again, it's not perfect. So while these multiple systems are effective and the best we have, it still doesn't give us that great outcome data that we're looking for. So what about a presumed diagnosis? So I listed previously that you really need a tissue diagnosis to absolutely confirm the disease. Well, we're trying to be better at that to avoid the delay in diagnosis, which can be up to as high as a decade in a lot of patients, which really is not acceptable. As recently as February of this year, ACOG, which is the governing body of OBGYN, published new clinical guidance aiming to shorten the time to diagnosis and improve access to care. And this is important because a lot of these first-line medical therapies are typically low risk, high reward in the appropriate patient. So it's very reasonable to give a patient a presumed diagnosis of endometriosis and get them started on treatment. Often, as patients are waiting for diagnoses, they can experience disease progression, new symptoms, declines in their quality of life, and increasing healthcare costs as well.
So now we'll switch gears a little bit and focus on the various types of treatment and talk a little bit about the nuances and specifics on that, starting with medical management. Right. So NSAIDs, like ibuprofen, Motrin, these are obviously great for their anti-inflammatory properties. There's actually, interestingly, no specific high-quality evidence that says this is first-line therapy for endometriosis per se, but it is very low cost, high availability, low side effect profile, and generally there is robust data showing its effectiveness in um, treating patients with painful cramps and menstrual cramps. So that could be very helpful as part of their endometriosis symptomatology. And then you see a very long list of various hormonal suppressive therapies, right? So hormonal suppression is very important because the endometriosis cells are stimulated by hormonal stimulation or flares. So suppressing them is very important, or regulating your cycles, for example. And there's various formulations. I won't go into all of them, but pill patches, rings, injections, IUDs, GnRH, active agents. GnRH is essentially a hormone or molecule that's made in your brain that tells your ovaries to function, and then cause those hormonal flares and cycles. So there are certain medications that target that and actually put you in this pseudo menopause state, which can be very suppressing for endometriosis with different side effects, of course. But I think the most important thing to take home from this slide is that there is no one best medication option. We do not have any strong or high quality data or trials that show that one medication option is superior to another. So really, it's a very patient-centered discussion about preferences, goals, timing, side effects, cost, and availability that really helps us decide what's the best choice for each patient. And obviously, we want to take a holistic approach as well, right? Because there's so many other comorbid conditions or issues associated with pain with endometriosis. We want to make sure that we optimize management for those as well. The advantages for medical management, I already touched on a little bit. It's low risk, right? Generally well tolerated. It's based on certain studies, it's been equally as effective as surgical therapy, so up to 75 to 85% improvement in symptoms. It may slow the progression of disease by reducing stimulation of endometriosis cell growth or abnormal tissue in the ovary, for example, like ovarian cysts. And it does avoid surgical risk and complications, obviously. But there are considerations, right? There's high rates of pain recurrence after discontinuation, which is not surprising. And many options do involve prevention of pregnancy because they're hormonal suppressive therapy. So you cannot get pregnant at the same time. That can be limiting for some patients. And that takes us to surgery, right? So when do we consider surgery? These are some basic points. This is not an exhaustive list for why, but some important things to consider. So for some patients, it's very important to establish a diagnosis, get tissue biopsy and pathology. It can also be very important for patients to understand why they're having this pain and have an answer to things. Um, to evaluate pain that is not responsive to medical management. That's very important as well. All patients respond to different therapies differently. And so for those who have really tried medicine or it's not working well for them, then we proceed with surgery and discuss surgical options. To manage or investigate ovarian masses, which are very important to know about, and then fertility concerns. And I put an asterisk there because that's a very um, girthy topic. So we'll touch on that briefly, but we often do that in coordination with our fertility specialists. One type of surgery that we do quite commonly is what we call the fertility uterine sparing approach or diagnostic laparoscopy with concurrent treatment of endometriosis if found, right? So that's laparoscopic excision or ablation of lesions. Excision being cutting out, right? Excising, taking it out, and then ablation meaning using some kind of energy source to burn or destroy cells. There's really no difference in pain scores between the two different techniques. It can be, for example, surgeon preference, surgeon technique, technical capabilities, location specific. A caveat, though, is that as a group at Hopkins, we tend to be more excisional because we find it can be helpful to have pathology to really confirm whether there's endometriosis or not. But also, sometimes if there's complex anatomic distortion, or say your lesion is close to the ureter or the bowel or the bladder, we're obviously not going to burn and damage those tissues, but we can still dissect spaces safely and excise the tissue safely. And when you burn lesions, you're not really controlling how deep or how wide you're burning things. And so some deeper nodules or deeper lesions could be missed or untreated. In general, based on our many studies, actually, patients are 3 times more likely to report improvement in pain symptoms if you actually do surgery with a surgeon who's comfortable with excising and treating endometriosis rather than just having a look and confirming whether or not it's there. And a little brief aside for endometriomas, which I think deserves a whole other talk as well, but given our time constraints, right? So when do we consider surgery? These are, as Dr. Frost mentioned before, these large, or not always large, I suppose, but cysts of endometriosis that grows in the ovary, and then they kind of bleed into the ovary and form these, for lack of a better term, chocolate cysts, because it's like this chocolatey brown fluid, which is old blood. We typically consider surgery when we're trying to relieve pain and symptoms, mass effect, right? Depending on the cyst size, that can be very important. And especially with concurrent management of subfertility or infertility, there's different considerations there as well. Importantly, surgery can reduce ovarian function in reserve because especially important for endometriomas because they're not true ovarian cysts like some patients have heard of dermoid cysts or cystadenomas or other basic ovarian cysts where you can peel the cyst wall from the ovary and it's like peeling an orange. The ovary itself is relatively unscathed and untouched and then the ovary heals normally. But actually for endometriomas, it's when the endometriosis cells is burrowed into the ovary essentially and bled into it. So the surrounding wall of the cyst is actually scarred ovarian tissue. And when you're peeling that out, you do have to peel that out to make sure you excise disease well, but it can take some eggs and ovarian tissue with it, unfortunately. There's definitely a higher risk of recurrence in this setting, right? So about 30% of women in 2 years after conservative fertility preserving surgery and treating these cysts and excising them, but keeping the ovary, of course, can have these cysts come back. And it can be a harbinger for more advanced disease. Once the disease has spread up that far up the ovaries to the pelvis, you can have more advanced stage disease where there's anatomic distortion, scar to bowel or bladder, uterus, other organs that are important to be thoughtful about, especially for surgical counseling.
Okay, so now looking at a little bit of more surgical management, but more of a definitive approach. So talking more about hysterectomy and variations of it. So hysterectomy is purely just removal of the uterus, and typically the cervix. When do we consider it? Well, again, there's a couple of reasons here, but a lot of it is, joint decision making. If you're unresponsive to medical therapy or prior surgical therapy, also typically, obviously, it's someone who doesn't have a desire for, personal childbearing or future fertility, or they've completed childbearing. And there is actually some data, again, a whole separate topic of patients with generalized pelvic pain with other sources of pain optimally managed that we can get a lot of benefit from hysterectomy alone. Of course, longer period of symptom relief, lower long-term need for additional surgeries or medications, which I think goes without saying. Of course, you lose fertility, so that's a big consideration. And of course, it's a more major abdominal surgery, especially with endometriosis. These surgeries can be more complex. When or when not to remove the ovaries. This could be an entire talk in itself. Typically, when I'm counseling patients about this topic alone can be as long as 20 minutes. So this slide does not do it justice. Our general practice is retaining the ovaries, especially given that we see most of our patients in a childbearing age. And far before the age of menopause. But there are lots of considerations. It's a very nuanced decision. It depends on the patient's age, the extent of disease, personal or family history, and again, a big part of it, which we should probably go first, is patient preference. But of course, the theory is that you're removing the main source of estrogen, so you're significantly increasing the efficacy of hysterectomy. But we see patients get a big benefit from hysterectomy alone. Outcomes, so these percentages are probably not overly surprising. The conservative approach, as Dr. Wu said, you can see an reoperation rate as high as 20 to 30% within 2 years, and that is highly variable based on what medication you're on, your extent of disease, et cetera. With definitive approach, you see that drop a good amount. With removal of the uterus-only hysterectomy, you can see it in as high as 10 to 15% of patients. Again, depends on the age of the patient and a lot of other factors. And with completely definitive therapy in only up to 5% of patients because of that theory of the Pseudomonas metaplasia that Dr. Wu previously mentioned. The big take home here is that multiple conservative surgeries has not been shown to be So it's not uncommon that I get patients asking, well, I had it diagnosed, when should I go back to have another surgery? When should I get things cleaned out again? We do not see that with every repeat surgery, conservative surgery with endometriosis. We tend to see less effect over time. And of course, it can come with increased surgical risks and adhesions or scar formation. But it doesn't mean you can't have, multiple conservative surgeries. It's very dependent on the patient. Really, we want to focus on the treatment of the pain symptoms and less so focusing as much on where each lesion is and what that means. It's a chronic condition, so it's a lifelong condition. It requires a lifelong management plan. It's not a quick diagnosis and fix. And long-term hormonal suppressive therapy is going to be the crux of therapy that you'll hear us talk about over and over again.
And finally, a few points on fertility and endometriosis management, which is, again, another whole talk in and of its own. But it's important to keep in mind that the diagnosis of endometriosis does not equal the diagnosis of infertility, right? It's not all Debbie Downer from there. So you can certainly have endometriosis, but still successfully conceive. Of course, we know that there are associations for the reasons we discussed before, so it's important to be thoughtful about that. And that's why we oftentimes coordinate our care with our fertility specialists. We strongly recommend fertility evaluation in patients, in appropriate patients who we talk to, because it's often multifactorial. There can be infertility from other factors in the female biology, as well as their partners, if applicable, like male factors. And patients with infertility symptoms concerning for endometriosis, we do know that surgery can improve spontaneous pregnancy, right? But specifically in the infertile population, not just any random patient walking on the street. But there is lack of utility in repetitive surgeries, so that's important to know. And then treatment planning and timing is, like I mentioned, often complex. So we do concurrent coordination and management with infertility specialists, especially given how sensitive the tubes, the ovaries, coordinating different kinds of care can be for that from that standpoint. And now we'll kind of shift gears again a little bit to talk about what's on the horizon, right? Some new hot topics that can be important to know and what we're still doing research on. One big thing is biomarkers for endometriosis. So biomarkers are a measurable substance in the body, like blood or urine, that can be used to help diagnose disease. This is very enticing because it does avoid the need for surgery or pathology for the official diagnosis, right? So it'd be great if you could pee into a cup or give blood work instead of undergoing a surgery to understand what's happening in your body. And it definitely will help reduce delays in diagnosis and treatment, which is very important for our patients. And however, the complex causes of endometriosis and associations with other conditions means there's a myriad of candidates, lots of different candidates, right? There can be proteins or inflammatory markers and even specific bacterial flora in the vagina, in the bowel, and other orifices. And of course, molecules related to genetic coding, which is not surprising. However, this is kind of a double-edged sword, right? With overwhelming possibilities, you really have a complex disease, which I think we discussed a lot by now. And so there's a lot of overlaps in autoimmune, endocrine, inflammatory physiology. And with many associated conditions, the overall accuracy of these biomarkers can be difficult to pin down or improve because so many things can be related just because you have an elevated testing on one thing may not mean that you necessarily have endometriosis. It could be many other things. So the bottom line for now is there's no clinically approved ideal or accurate biomarker for endometriosis, so we're still searching.
And last but certainly not least, lifestyle and endometriosis. Now, this is a topic I get asked about a lot as early as, one of my telemedicine visits this morning is, what can I do with my diet? What can reduce the symptoms of endometriosis? Now, the bottom line is there's nothing hard and fast and true, but there is a lot of research going on in culinary medicine. Not surprisingly, things you see here are things that make overall health better. So the Mediterranean diet, the dairies, the omega-3 fatty acids, fiber, antioxidants, and unsurprisingly, and sadly, all of the, many of the good things in life can have negative consequences or worsen symptoms like caffeine, alcohol, red meat. But what I tell most patients is don't drastically change your diet just to try to improve endometriosis symptoms because you really want a balance and none of this is hard and fast data. In terms of exercise, there's been no data to suggest that one specific exercise is superior to another. Regular combination exercise is most effective. And then stress management, sleep hygiene, right? All these things that really are beneficial, holistically for our health but have been shown to have some good data in patients with endometriosis. Acupuncture, interestingly, has been shown to alleviate dysmenorrhea or painful cycles and pelvic pain in patients affected by endometriosis. The downside, of course, is a lot of these sites do not take insurance. There is a location at Hopkins that does treat some of our endometriosis patients. So there is some promising data there. And then lastly, Dr. Wu and I are only a small part of this big group at Johns Hopkins. We make up the minimally invasive surgical group, and of course, the number below is available to request a consult.
And it's important to mention to request a MIGS or minimally invasive gynecologic surgery consult. This is a subspecialist group that treat endometriosis, not just here at Hopkins, but throughout other large institutions. It's not just surgery. We can also talk about medical management and other thoughtful concerns that patients might have because the scheduling can get a little crazy. So we want to make sure you don't get lost or go somewhere random. And then I think this slide is just a reminder on how to ask questions and have a fruitful discussion with us if you would like. And then again, that number is down there for our consultation service.
All right, so I think we're going to move on to comments and questions. So looks like one of the first questions is, does the age of the patient influence treatment recommendations? Absolutely, right? There's, like we mentioned a lot of these slides, it's such a nuanced decision, right? It's not just your age, it's, what treatments have you had before? Do you have significant side effects to hormonal medications? Can you even take hormonal medications, or do you prefer just to not take them? Are you completed with childbearing, or do you prefer to never bear children of your own? So it means that, based on your symptoms and your history, it can open up other treatment options. So I try to really get a sense from patients about what their priorities are and what their goals are, so that I know what treatments to offer. Although we, always give the breadth of treatment options, we really try to tailor it to the patient. So yes, and a patient who's had 4 conservative surgeries before and they have 3 children now, and they're having still significant symptoms, yes, sometimes I'll say, really, hysterectomy is probably the most effective and appropriate treatment option for you at this point, but that doesn't exclude the option for other recommendations. So yeah, it's a complicated topic. One of my mentors in fellowship said that you see a patient for endometriosis on your schedule and you're already 30 minutes behind because it's a complex conversation.
All right.
Dr. Wu, can you see the questions?
Yeah, I can. So the next question is, how do you define a conservative surgery? I think that can be defined uh, simply or not, or in a complex manner, right? Depending what we're talking about. So, oh, I think the question just went away. But anyway, I think I can see it. So essentially, sometimes when we talk about conservative surgery, we mean uterine fertility sparing surgery. So meaning we're not going in with the intention of taking out the uterus or ovaries and etc. And that's more of like a technical terminology, or like conservative in a sense. But we also need to be thoughtful. That doesn't necessarily mean conserve. It can mean, I guess, it can mean multiple things, but it doesn't necessarily mean conservative as in, oh, we're just gonna not do as much as we can. But we do want to have limitations and discuss that very important with patients during our consults because we can still try to optimally resect disease within the confines and limitations of what we're going to do based on patient goals, preferences, right? A lot of our endometriosis conversations really is patient preference and goals at the forefront because it really kind of dictates what we can do, how much we can do. For example, let's pretend you have a patient who has advanced stage endometriosis, or at least pretty severe endometriosis, let's say, involving the ovaries and maybe a tube and are actively seeking fertility care or trying to get pregnant, it is still a conservative surgery, but we're going to try to optimally resect disease and normalize anatomy, break down scar tissue, remove the cyst, and then make sure that the tube is not too damaged. And if it is too damaged and it might impact fertility, that we actually need to treat that as well. But at the same time, if there's a lot of scar tissue involving the bowel and the uterus, we're going to try to normalize anatomy for that within the confines of knowing that we're not trying to go all the way deep into the pelvis to remove the cervix or the uterus and increase, risk for bowel injury or bladder injury, right? So it's kind of a very well thought out balance to really optimal benefits, minimize risk, right? Which is everything for medicine, but it's especially important when you're doing complex surgery for endometriosis.
The next question is, would you recommend to take hormonal treatment such as birth control pills if it helps the patient for a long period of time? I'm going to try to guess where you're going with this, but I guess it's are we treating with a presumed diagnosis or a known diagnosis? Well, it doesn't really matter, as we discussed in previous slides. So if someone's getting benefit from suppressive therapy, meaning any of those kind of hormonal medications we listed, yes, continue on them, right? Whether you have the diagnosis or not. A big factor, which we didn't touch on as much, is when I'm taking patients to the operating room for either evaluation for endo or known endo and resection, I tell people, even if we find endometriosis, even if we remove it, we're still going to recommend ongoing hormonal therapy because it does keep symptoms at bay and control them and slow the time to recurrence of disease. It does not necessarily completely prevent recurrence, but it slows the time. So, certainly as patients get closer to a menopausal age, we sometimes get more cautious with certain hormonal therapies, but that's a whole separate topic and not the bulk of the patients we see. So yes, if you're getting benefit, the hormonal therapy can continue to suppress the disease and slow the chance that it can come back.
Okay, so the next question. I'm a postpartum nurse at Sibley. Welcome. What else should I look out for in patients recovering postpartum after endometriosis diagnosis, for patients with surgical intervention previously or not? I'm trying to think. I don't believe there's anything very specific, and Dr. Frost, jump in if you're thinking of anything in the immediate postpartum period, as in just delivered a baby, in the postpartum ward or unit that's recovering well. But I think it is important to be thoughtful about as things normalize after pregnancy and cycles return, right? Depending on breastfeeding and other things. So we do know that during pregnancy, endometriosis remains overall dormant and quiescent because you need the period flares to cause more growth and increase in cyst size, for example, or worsening disease. But you're not really going to have periods when you're pregnant. And so that stimulation is all focused on the baby. And obviously going to have painful periods during pregnancy, so that kind of becomes quiescent. But it is not a cure, right? It's not going to physically treat the disease during that time frame. So once you exit that usual like 4 to 6 week physiologic period where your body returns less pregnancy state, more normal unpregnant state. And again, depending on breastfeeding and how long that suppresses your cycles and stimulation. When you see any return of symptoms, it's thoughtful if you have a patient who has that history to revisit any concerns for continued painful periods, worsening periods, and different options for medical management, for example, that might be double as contraception or birth control if that's important for the patient's family planning goals, as a brief example.
Yeah, agreed. I was going to say mostly that the good thing about pregnancy is it's a nice environment for endometriosis and breastfeeding. Right. So it all depends on, some people have their cycles return quickly, even in exclusive breastfeeding. Some people are amenorrheic or mean without a cycle the entire time they breastfeed. So that can change the recommendation of going back on some sort of hormonal suppressive therapy. But we do recommend outside of the pregnant state, if someone has diagnosed confirmed endometriosis, that long term they do stay typically on some sort of suppressive therapy. And breastfeeding counts as that if someone has really suppressed their cycles well. So it can be a really nice environment, but it's highly dependent on, how advanced their disease was previously. And sometimes we monitor with ultrasound or imaging studies, especially in patients with known endometriomas, which are, the bulk of what can get picked up on imaging. If you have a normal pelvic ultrasound, is it unusual to go straight to laparoscopy and not have a pelvic MRI to rule out other reasons for ongoing pelvic pain before going to surgery? Dr. Wu and I are both smiling a little bit because we love MRIs. So we're going to be really biased in this topic, but I will say I take lots of patients to the operating room without an MRI. So it is certainly not a required part of the workup. It certainly is more sensitive. So sometimes you do get that extra information. So I do talk to patients about it as an option as we're considering, their evaluation and workup. But it is completely appropriate to proceed to the operating room without an MRI. For a diagnostic laparoscopy. And I would say that's probably the mainstay of therapy. It is, uncommon. The only scenario which I give is, we could have a normal ultrasound and then we go in and find severe advanced stage 4 endometriosis. And sometimes we have to say, hey, we need to have another conversation before we really go do this, complex excisional surgery. slightly more uncommon that you see that drastic difference in findings. But we will order a lot of MRIs. There's nothing wrong with them. They give extra information, and a lot of patients take us up on it when we offer it, but it's certainly not required.
Okay. Next topic, does endometriosis medical management continue after menopause? In general, I would say no, but I'm going to elaborate on that a little bit. We know that, in menopause is typically when, right, you no longer have periods, so the ovaries would essentially become quiet, and so you're not stimulating endometriosis to grow. And therefore, in that setting, you don't really need any additional hormonal suppression because there is nothing to truly suppress. The lesions themselves don't necessarily melt away or disappear, if that is applicable to the patient. But the actual disease should not continue to grow or cause issues. And certainly you should not have, quote, painful periods. Now, one caveat to that, of course, if there is severe disease that tethers organs or a large mass and things like that, that's obviously also not going to disappear. So there is utility in having a more, I think, fruitful and detailed conversation with us about what to think about even after menopause. I will say there are not common, but also not uncommon, I guess, given we see pretty complex patients, especially in the operating room, where sometimes you undergo surgical menopause, right? So, because of the complexity of your disease, and this is, of course, discussed with the patient ahead of time, as well. So, we're all on the same page because no one likes to be blindsided after major surgery. But, you can lose both ovaries. And with that, you do go into surgical menopause. And in that setting, yes, things do become quiescent as well. But there have been certain studies long term about possibly certain, for example, if you go on HRT, right, which is hormone replacement therapy, and you're actually of a younger age, for example, less than 50, and you do need some hormones to support your bone and heart health, that it can reincite certain kinds of endometriosis lesions. And so we are thoughtful about kind of talking to patients about that kind of risk.
So a few questions that I'll answer separately. So can endometriosis be prevented? We wish. It would be great. You could theorize, again, because we don't know about the diagnosis a lot of the time, in that in young patients who are placed on birth control pills for contraception, for a history of painful cycles, maybe they're slowing their time to progression of disease without even knowing they have the disease. But it's a caveat, right? Because a lot of patients are starting these medications because of painful cycles and probably have a higher chance of having the disease. So it's not as much prevention, and you can't decide when your periods start, how long they last for, etc. So no, not really. Are endometrial polyps related? No. So we do not see an association with endometriosis and polyps, which is typically a benign overgrowth of the inside lining of the uterus. But that being said, it's not uncommon that we see combined pathology present in a lot of our patients. Fibroids and endometriosis, typically not related, but both hormonally stimulated, and a variety of other factors. How long does it take endometriosis to develop? Great question too. We wish, a lot of these answers are going to be highly unsatisfying. We wish we knew why someone has advanced stage disease at the age of 17, when they've only had their cycle for, 5 years. Versus someone has only stage 1 disease at the age of 45, who's had monthly cycles for their whole life, and has never had a baby, for example. We really don't know. And it's unfortunate. There's still so much research needed in the field. And then what's the size cutoff for medical management versus surgery? This is a whole separate complex conversation that could require a whole visit. But we do think in terms of just, again, personalized, but endometrioma size or cyst size, as we get closer to that 4 to 5 centimeter cutoff, is sometimes when we start to talk more about surgery. But there's a lot of factors that go into that, seemingly black and white number that I listed. And can hormonal suppression reduce the size? So this is an interesting topic, actually. We used to tell patients not really. It can stabilize disease of a cyst, but we don't expect it to really shrink it. And newer data has come out that medical therapy actually can modestly reduce the size of endometriomas. So that's highly dependent on, fertility plans, the size of endometrioma, the symptoms you're having. But we have gotten more promising data on that over time.
I think the next question is, do symptoms of endometriosis change during or after pregnancy? I feel like we already touched on that quite a bit. So if the
Dr.
question
Wu, I
asker
think you're
has.
seeing a different summary. I think the next question she put in was, are there cases where endometriosis can grow
Oh,
even during hormonal treatment?
okay. Um, yes, unfortunately. So, again, a lot of things are very patient specific. Everyone reacts to hormonal treatment very differently and have different symptoms and progression of disease. So even while on hormonal suppression, it is the best we have with modern medical technology, unfortunately, but it doesn't guarantee that, for example, like what Dr. Frost just mentioned, that your cyst doesn't grow or that the disease itself doesn't progress. One very helpful measure that, especially in patients who we've performed surgery or had surgical treatment before and now following with medical treatment, right, is as we I think also mentioned in our slide that we really want to focus on quality of life and symptom management, right? So, if the hormonal therapy is happily helping a patient to become amenorrheic, meaning not have any painful periods, and overall feeling well without major side effects, then we're not really focused on, oh, what if there's something silently progressing? Chances are it's probably not overall, but still, we want to make sure that we focus on the quality of life and symptom control as opposed to actual lesion itself. It is unfortunately possible for disease to progress. And so we often do surveillance ultrasounds or imaging, for example, in those patients with specifically within the context of like large ovarian cysts, like endometriomas that we want to follow over time, or if we know that you have severe disease and maybe considering future fertility and had surgery in the past, and we want to get a better look, we can always have follow-ups and be thoughtful about any changes in the patient's symptom profile.
So the next question is, there's lots of research emerging on biomarkers, as we touched on. I'm sure it won't be a diagnostic measure, but it will help identify patients who should be investigated. How do you think these might change the currently understood prevalence rates, especially through the lens of social determinants of health? I mean, great, very great, very complex question. I think it would improve things significantly, unfortunately, and I think this is changing. It used to be a disease of Caucasian women. That was the classic speaking and theory. And so obviously that impacts significantly our majorly underrepresented populations that we see around the world and especially in our community. So, we try to be as unbiased as we can. I think, we as surgeons, because we see such high prevalence rates, whether it's incidental or taking patients to surgery, we realize that that is actually not true anymore, which I think helps our, to unbias our, diagnosis. But I think it would help significantly, especially other providers who aren't as aware of how, spread the disease can be across various, racial and ethnic groups. So I think it would improve things significantly. We're all really hopeful that biomarkers will be promising. I think we still have a lot of time, to be honest, until there is a definitive biomarker for endometriosis. But I think it would be great, and it would be a great adjunct to our evaluation criteria.
I know, right? That would be the day. I'm looking forward to it. Can't wait. Is it common for patients to have multiple excision surgeries or have an excision surgery and then a hysterectomy? Um, yes and no. So we're a little bit biased because we are a high volume surgical center, and Dr. Frost, we love to do surgery, but surgery isn't always the right answer. It needs to be patient first, make sure that we have goals in mind and that your outcomes can be optimized, right? So it's always important to have a thoughtful discussion about that. Having said that, though, we do often see patients who have had a prior diagnostic laparoscopy, for example, from an outside center and noted some disease that then was not able to be fully excised, which is appropriate because given the surgeon's capabilities or comfort level, you do not want to do anything cowboyish or risk damage to organs or unnecessary risk for the patient. So then we end up going back to do a more thoughtful counseling and surgery for that. You can certainly have excisional surgery and then a hysterectomy. That's not uncommon either, right? One for potentially diagnosis or try to help improve symptoms. And maybe during that phase of life, the patient was trying to get pregnant or had fertility goals in mind. And then certainly for several of our patients that I just saw yesterday, actually, over time they change how they approach things and their goals change and no longer wishing for fertility, but rather like a cure, right? For periods, cramps, and have a lower risk of recurrence for endometriosis. So hysterectomy is more appropriate. I will say though, like we had mentioned before, multiple excision surgeries, we don't typically say or even like to or counsel towards like, okay, you had a surgery in 2000 now or 2026, it's time to plan for one to 28 and then 30 and 32, right? Like nobody wants that kind of trauma or consistent surgery in their healthcare. So really what we want to be thoughtful about is what are the benefits and limitations of that. And it does get a little complicated if you start talking about fertility because there are certain things related to tubes and ovaries that might impact fertility care, which then leads us to make different decisions on repeat surgeries. But, you should see us for a consult and talk about that if that's applicable.
Um, the next question, and Dr. Wu, I might read them because I think our moderators are summarizing them in a different place than you're reading. But could you expand more on excision versus ablation? Since we mentioned ablation might miss deeper lesions, should we be weary of it being performed? So I will say we're pretty biased about this. And again, we always do have to fall on the data, the big studies that have really been done looking at this, and have done a pretty deep dive into this, looking at this topic, is that the outcomes in terms of improvement in symptoms are the same regardless of the treatment performed. That's what the data shows. We can believe it or not believe it, but that's what the data shows. We tend to prefer excision. I think, we're surgeons. We like to remove abnormal tissue and get it out of the body, right? It's just kind of the way that we operate, pun intended. But there is not a difference in outcomes. I would say if you know that there's a deep, hard nodule somewhere, ablation's probably not the best. And the place where they do not see an improvement with ablation is with painful bowel movements. Now, it's a really specific topic, and I think it has to do more with these are a very small subset of patients that might have infiltrating disease around the bowel. And so obviously ablating these areas is not appropriate. So no, I wouldn't necessarily be weary, but you will see, amongst some of the, minimally invasive GYN surgeons that are trained in endometriosis surgery is that a lot of us tend to favor excising lesions to get pathology as well.
I will just add one thing to think about, and apologies if I missed this, Dr. Frost, when you said it, but when you have certain disease on certain organs that we can't technically remove, like for example, if sometimes you have endometriosis nodules or lesions on the uterus itself, right, and we're trying to preserve the uterus, you can ablate those lesions because you're obviously not going to cut out portions of your uterus, but you want to try to destroy some cells that are impacting that. And it depends on the preferences and goals that we talk about ahead of time.
Yeah, great point. Thanks. The next question, Dr. Rose, what is the current opinion on using combined birth control, progesterone and
Oh yeah, why
estrogen
am I
pills for treating
not
endometriosis?
seeing
If
that?
this involved estrogen sensitive cells, could you actually progress the disease?
Sorry, I missed that because I'm trying to find where you're
Okay, I'll,
seeing
I'll
that.
answer
It's
and
a different
then
chat box. Oh, is it the webinar chat? Got it. Okay, I see it. What is the current opinion on using combination birth
short answer
control?
really is no, because the way that birth control pills work is through negative feedback. And so it does sound contradictory that we're giving you estrogen and it's an estrogen sensitive disorder. But the way that the dosage of the medications work, it functions by giving negative feedback to the brain and actually doing the opposite on the system. So it can be confusing, but no, it does not progress the disease.
And then that's it, right? I think those are all
That's
the questions.
it for at the moment. I don't know if they're
Okay.
summarizing any additional questions. Oh, here
There's
you
like
go.
additional questions here though in another box.
Does a hemorrhagic cyst, can it be mistaken with an endometrioma?
Well, that's a great question, actually. And I guess the short answer is yes, because that's something we often talk to patients a lot. When you have a cyst in the ovary, a bloody cyst, I guess, right? A hemorrhagic cyst, when you ovulate and some blood accumulates in the ovary, it can oftentimes be confused with an endometriosis cyst because it's also old blood in the ovary, but that's mostly on ultrasound. And one way we differentiate is your provider would order a follow-up imaging, right? Because functional physiologic cysts like an ovulation cyst will go away, but endometriomas are more persistent and can even grow over time. And in general, MRIs are often pretty good too at delineating. I'm not going to go into all the specific nitty-gritties. We're going to the weeds of physics, but like the way that MRI signaling works, we can sometimes differentiate hemorrhagic cysts better than endometriomas, but that's not absolute. Um,
All right. And then I think this is probably going to be our last question because we're wrapping up on time here. But do you have any recommendations for how to coordinate treatment and care across specialties with many comorbidities that are associated? That's really tough. It's challenging. I think
Mm,
one thing that I found can be beneficial is patients that have their care in one location. It's not uncommon that we'll see patients travel from out of state, for example, and they have a rheumatologist at home, and then they have a endocrinologist at a different hospital, and then they have us here, and their primary care is private and can't see any of their notes. And although, the medical record has made it easier a little bit to communicate with physicians, it does make the care a bit more siloed, because you can't directly send an Epic message or see the note from the previous provider. So I think that's the best that we can do, but that's not possible for all patients based on insurance status and where they live. And so I realize that that is idealistic. I think continuing to educate the providers that aren't us, right, aren't the people that are the specialists about the disease process, so that they have the clinical knowledge, but that's also difficult because medicine has become just a bit more siloed in general over time. So that's a big mountain to climb, but it would be a really great thing to have more specialists on the same page, and I hope we can be better for that. So thank you guys so much. Again, I think you have all the contacts for emailing additional questions. We have all of our names within the group, the ability to schedule an additional consult if you have, specific questions about yourself. And we hope that you found this informative.
thank you for your time. Thank you for coming.